Thank you to the British Pharmacological Society for hosting this lecture. My main laboratory, the in vitro human heart laboratory, is located at the Prince Charles Hospital. The hospital opened in 1954 as the Brisbane Chest Hospital, but by 1974, the monarchists got their way and renamed it the Prince Charles Hospital. First coronary artery bypass surgery took place there at 1970, the first heart transplant at 1990. My laboratory is located in that bottom building, the orange one, and it is literally 2 minutes walk from the cardiac surgical theatres, and that is a very important feature of that laboratory. Also lecturer at Queensland University of Technology, which is shown in the foreground there, and next to the botanical gardens on the right-hand side. And you can see Brisbane just in the background there. And you can see that we're surrounded by the Brisbane River. And just sometimes it can get quite angry and it can cause widespread flooding to Brisbane. So I was very sorry to hear about flooding, very severe flooding in the northern part of England last week. So today I'm going to talk about beta-1 and beta-2 adrenoceptors, describe their distribution, studies on contractility, and in relation to polymorphisms and in the context of heart failure, studies on regulation of contractility by chronic administration of beta blockers, some work on phosphodiesterases, some very new work on ventricular arrhythmias, and some work on beta-3 adrenoceptors. And a lot of this latter part of this talk was done with my very good friend and colleague, Alberto Kalman, who'll be known to many in this audience. So there are at least two cardiostimulatory beta-adrenoceptors, beta-1 and beta-2, and both of those exist as polymorphisms. So I can almost hear you say, but what about beta-3 adrenoceptors? And okay. So beta-1 and beta-2 adrenoceptors coexist in all cardiomyocyte regions that we have investigated so far. Beta-1 adrenoceptors predominate in atrial muscle, ventricular muscle, the sinoatrial node, and this region around or adjacent to the sinoatrial node called the paranodal region, and the atrioventricular node. But beta-1 adrenoceptors are less dense than beta-2 adrenoceptors in the bundle of His. And shown here are some, I guess, ancient autoradiographs prepared with iodosinopindolol, and these show the density and distribution of beta-1 adrenoceptors and beta-2 adrenoceptors in this discrete region of the atrioventricular node surrounding ventricular and atrial muscle, and also in the bundle of His. For our ventricular contractility work, we obtain explanted hearts from patients with terminal heart failure undergoing heart transplantation. These are rapidly transferred to the laboratory and ventricular trabeculae are dissected from those. And just shown in this right-hand panel is the right side of the heart, which has been opened up, and you can orientate yourself. So this is the ventricular chamber, atrial muscle just shown there, the tricuspid valve, and we take out these small ventricular trabeculae, and I've just managed to catch one here, and there's a tie on that. But you can see in this heart, this is an ischemic heart disease, you can see these large areas of necrosis, and of course we avoid those. These trabeculae, they're mounted on tissue electrode blocks and then experimented on. And as you can see, students and postdocs are really very happy to work at any hour of the day and also the night. We also obtain a large quantity of human right atrial appendages. These are from patients with coronary artery bypass surgery. And I guess, sadly, I guess we get about 4, or we can get up to about 4 of those per day. So activation of both beta-1 and also beta-2 adrenoceptors mediate very powerful cardiostimulant effects in the human heart. So shown here are original traces and showing fast speed recordings taken before and then after the administration of adrenaline at beta-2 adrenoceptors, noradrenaline at beta-1 adrenoceptors in right ventricular trabeculae. And the administration here is just shown as a slower speed recording showing the onset of effects. And what you can see here is that both adrenaline and noradrenaline mediate very powerful, very rapid increases in contractile force. This is associated with shortening of the duration of contraction. And also this is associated with phosphorylation of proteins implicated in contraction and relaxation, namely phospholambin, also troponin I, and also C protein. And much the same thing was observed in human right atrium, except that the duration of the contraction is much shorter in atrium compared to ventricle. But not all beta-adrenoceptors are the same. They exist as polymorphisms. There are two common polymorphisms in the beta-1 adrenoceptor, and there are three common polymorphisms in the beta-2 adrenoceptor. And so the question we asked is the potency and efficacy of noradrenaline and adrenaline determined by beta-1 and beta-2 adrenoceptor polymorphisms? And we used right atrial appendages. We obtained a blood sample from patients with coronary artery disease undergoing coronary artery bypass surgery. And shown here are concentration effect curves to noradrenaline at beta-1 adrenoceptor polymorphisms. And you can see here that the potency and also maximal effects were identical across all beta-1 adrenoceptor polymorphisms. And so we convinced the editors of JACC that this was in fact an important finding. So we did the same exercise at beta-2 adrenoceptors, at beta-2 adrenoceptor polymorphisms, and shown here are concentration effect curves at beta-2 adrenoceptor polymorphisms, concentration effect curves to adrenaline this time. And again, you can see that the potency and the maximal effects were identical across all beta-adrenoceptor or beta-2 adrenoceptor polymorphisms. And so we can summarise at least that the potency and efficacy of noradrenaline is conserved across beta-1 adrenoceptor polymorphisms, and similarly adrenaline, the potency and efficacy is conserved across beta-2 adrenoceptor polymorphisms, at least in right atrium from coronary artery bypass grafting patients. So does that mean that are all beta-adrenoceptor polymorphisms redundant? And so we addressed this question in a slightly different way, and we asked whether beta-adrenoceptor polymorphisms determine beta blocker outcomes in human heart failure. So beta blockers are an important therapeutic strategy for the management of patients with heart failure. They produce hemodynamic improvement, they produce reductions in morbidity, they produce reductions in mortality, as shown in this representative trial here of Carvedilol in patients with severe chronic heart failure with left ventricular ejection fraction less than 25%. This study involved about 2,300 patients, and the chronic administration of Carvedilol produced a reduction in mortality risk of 35%, resulting in early termination of the trial. Earlier on, Mike Bristow and colleagues showed a dose-dependent increase in left ventricular ejection fraction following administration of Carvedilol for 6 months in patients with ischemic or non-ischemic dilated cardiomyopathy with a left ventricular ejection fraction of less than 35%. However, not all patients respond equally to beta blocker treatment. And so Lu Chen in my laboratory studied 135 patients with non-ischemic cardiomyopathy with left ventricular ejection fraction of 23%. And patients were administered Carvedilol for over 1 year, or just over 1 year. And sadly, 32%, about a third of patients had a left ventricular ejection fraction, increase of less than 5%. And so we asked whether β-Adrenoceptor polymorphisms were responsible for this variability. And so we recruited patients who were aged over 18 years with symptoms of heart failure, NYHA, functional class 2 to 3, left ventricular ejection fraction less than 35%, and these patients had non-ischemic dilated cardiomyopathy. And there were a number of exclusion criteria as well. Patients were administered Carvedilol for a period of 1 year, 25 milligrams twice daily if less than 80 kilograms, 50 milligrams twice daily if over 80 kilograms. A requirement was a satisfactory record of serial echocardiography data before Carvedilol initiation and then after 1 year of administration, and a blood sample for genotyping beta-1 and beta-2 adrenoceptor polymorphisms. And we showed a strong gene-dose relationship for the arginine 389 glycine beta-1 adrenoceptor polymorphisms. And the arginine polymorphism provided the greatest improvement in left ventricular ejection fraction, whereas there was little or no improvement with the glycine 389 polymorphism. We were also able to do genotyping at the 389 position in a homogeneous population of beta-1 serine 49 patients, and of course we showed the same relationship. There was no dependence of other beta-adrenoceptor polymorphisms for improvements in left ventricular ejection fraction. And so we can conclude that Carvedilol causes greater improvement in left ventricular ejection fraction in non-ischemic dilated cardiomyopathy patients with arginine 389 beta-1 adrenoceptors. And these contribute, at least in part, I guess, to variable beta blocker responses. So heart failure is characterized by an increase in sympathetic nervous system activity, increased levels of noradrenaline, desensitization of beta-1 adrenoceptors, and downregulation of beta-1 adrenoceptors. And so we asked, does chronic administration of blockers modify inotropic responses through activation of beta-1 and also beta-2 adrenoceptors? And we had the opportunity to study patients who were chronically administered metoprolol and also Carvedilol. And shown here are concentration effect curves to noradrenaline at beta-1 adrenoceptors and beta-2 and adrenaline at beta-2 adrenoceptors in human right ventricular trabeculae, and from patients that were not beta blocked, and also patients that were chronically administered metoprolol, and also patients that were chronically administered Carvedilol. So for patients that were chronically administered metoprolol, there was supersensitivity of both beta-1 and also beta-2 adrenoceptors. But so are all beta blockers the same? And the answer is no. So look what happens with Carvedilol. There was no change in potency at beta-1 adrenoceptors, but there was a 16-fold reduction in potency of adrenaline at beta-2 adrenoceptors in patients that were chronically administered Carvedilol. And so at this point, I want to summarise a lot of work that's been done by other workers and some of it by us as well. So both in the human heart, noradrenaline and adrenaline bind to beta-1 and beta-2 adrenoceptors and activate those receptors. They induce a conformational change which causes the dissociation of the alpha subunit of the G protein, which then diffuses to adenyl cyclase. Adenyl cyclase then causes or catalyses the production of cyclic AMP, which then goes on through a number of biochemical processes or steps to cause cardiostimulant effects in the heart. Cyclic AMP is metabolized by phosphodiesterase. And so potentially one important way of regulating contractility is through phosphodiesterases. And so we asked just a simple question: do common phosphodiesterases, PDE3, PDE4, do they control beta-1 and beta-2 adrenoceptor-mediated responses? And so we used human ventricular trabeculae from explanted hearts. 5 hearts were non-beta blocked. 15 patients were chronically administered metoprolol, and 11 were chronically administered carvedilol. Beta-1 adrenoceptor activation with noradrenaline, beta-2 activation with adrenaline, PDE3 inhibition with celostamide, and PDE4 inhibition with rolopram. And this work was done in collaboration with Torsten Christ at the Dresden University of Technology. So he had a laboratory which was very similar, which is similar to mine. And we worked independently, and then at the end of our studies, we were able to combine our data. And shown here, first of all, are studies in non-beta block patients, and shown are concentration effect curves to noradrenaline and adrenaline in the absence and presence of the PDE3 inhibitor, celostamide. And you can see that for both noradrenaline and adrenaline, there was a small increase in potency, which was not significant. So what about patients that were chronically administered metoprolol, and shown here a concentration effects for noradrenaline on the left-hand side, for adrenaline on the right-hand side, in the absence and then in the presence of PDE3 inhibitor celostamide, the PDE4 inhibitor rolopram, and then both celostamide and rolopram together. And I think if you look at these carefully, you can see that there was a supersensitivity of both noradrenaline and also adrenaline effects in trabeculae that had been treated with the PDE3 inhibitor celostamide. The next slide quantitates the data, shows concentration effect curves, again to noradrenaline and adrenaline in the absence and presence of rolopram, the PDE4 inhibitor, celostamide, the PDE3 inhibitor. And celostamide potentiated the effects of both noradrenaline and adrenaline, but there was no effect of the PDE4 inhibitor, rolopram. So what about in patients that were chronically administered carvedilol? And again, the same format as in the previous slide. Shown on the left-hand side, there are concentration effects to noradrenaline at beta-1 adrenoceptors, adrenaline at beta-2 adrenoceptors in the absence and presence of celostamide, rolopram, and then both of them combined together. So in some of these hearts, in patients who have been chronically administered carvedilol, the beta-2 responses are really quite poor. So this is adrenaline in the absence of any phosphodiesterase inhibitors. And you can see that the response to adrenaline is markedly potentiated in the presence of celostamide, the PDE3 inhibitor, but not the PDE4 inhibitor. The next slide quantitates the data. It again shows concentration effect curves to noradrenaline, adrenaline in the absence and presence of the PDE3 inhibitors in patients that have been chronically administered the beta blocker carvedilol. And you can see here that there was no change in potency for noradrenaline in the presence of celostamide or rolopram. But look what happens at the beta-2 adrenoceptor. There is a marked potentiation of the effects of adrenaline in the presence of the PDE3 inhibitor, celostamide, but not the PDE4 inhibitor, rolopram. And so we can summarise this work and say carvedilol treatment, which is what I just showed you, of heart failure patients, it markedly facilitates PDE3-induced reductions of inotropic, lusotropic, I haven't shown you that data, effects mediated through beta-2 adrenoceptors. So carvedilol is somehow facilitating PDE3 effects. Metoprolol treatment of patients induces a moderate control of PDE3 effects, PDE of effects mediated through beta-1 and beta-2 adrenoceptors. And we didn't see any effect of PDE4 inhibition. I just want to move on to some work that we are doing at the moment on ventricular arrhythmias, and this is unpublished. So in human heart failure, approximately 50% of patients die of sudden death, presumably through a ventricular arrhythmia. And so if we consider the work that I have already presented then for beta-1 and beta-2 adrenoceptors in human heart, both beta-1 and also beta-2 adrenoceptors are tightly coupled to the GS-alpha protein cyclic AMP pathway. And these are controlled by phosphodiesterases, or at least we showed PDE3. And so the hypotheses that we have developed are that both beta-1 and beta-2 adrenoceptors mediate ventricular arrhythmias, and that these may be controlled by phosphodiesterases. And so to investigate this, we set up an in vitro human ventricular arrhythmia model. So we obtained right ventricular trabeculae from patients with terminal heart failure undergoing heart transplantation. We set them up on a tissue electrode block. We carry out a length tension curve to determine maximal contraction. There we incubate them with drugs, so phenoxybenzamine, and either CGP 2071-2A, a beta-1 antagonist, or ICI, a beta-2 antagonist, in the absence or presence of celostamide, the PDE3 inhibitor, or roloprab, the PDE4 inhibitor. So routinely we have 20 trabeculae running simultaneously in the laboratory, so this enables us to look at lots and lots of conditions. We then turn the stimulator off, and we don't get any contractions at all. And then we run a concentration effect curve to noradrenaline or adrenaline with 15-minute incubation periods, and we look and we wait and we sit around and look for to observe the possibility of arrhythmic or spontaneous contractions. But first of all, I want to show you what an electrically stimulated contraction looks like in a right ventricular trabeculae. So this was in a male that was 66 years old with ischemic heart disease, chronically administered Carvedilol. And these are electrically stimulated contractions that just happen to be incubated, this particular trabeculae incubated with a beta-2 blocker and also celostamide. But what I want you to notice, though, is the uniformity of these contractions. They are all the similar size, similar duration, and they have a very stable baseline. So these are original recordings of beta-1 adrenoceptor-mediated spontaneous contractions. And again, in this patient, the 66-year-old male with ischemic heart disease being chronically administered Carvedilol. And the first time we saw spontaneous contractions was at a concentration of noradrenaline 2 micromolar and the presence of the PDE3 inhibitor, celostamide. And you can see these spontaneous contractions, and they occur fairly regularly. But they actually started down here. So if you blow this scale up, as I've done here in this middle tracing, you can just see the start of these spontaneous contractions. So there's a bit of noise there, and there's a contraction, maybe there, don't know, but there's looks like another one there. And if we blow this first contraction up, we can have a closer look at it. So this is it on a much expanded time scale. You can see that it's associated with an after contraction. But also look at how long this contraction takes. It's about 1 second. Remember, our hearts beat at about every second as well. And so the next slide quantitates the data. And I remind you that this is really work in progress still. And this is from 22 consecutive hearts that we obtained from heart transplantation. And it shows concentration, or attempts to show concentration effect curves for noradrenaline in the absence and presence of celostamide, the PDE3 inhibitor, and in the absence and presence of roloprab, the PDE4 inhibitor. And you can see that there is a concentration dependence, and statistically, noradrenaline produced on its own, it produced spontaneous contractions at 6 micromolar, and the threshold appeared to be reduced in the presence of the PDE3 inhibitor, and not really with the PDE4 inhibitor. So the question then that we asked is, do beta-2 adrenoceptors mediate spontaneous contractions or arrhythmic contractions as well? Well, we actually didn't see any in this patient that was chronically administered Carvedilol, which was really quite interesting. But we did in this 50-year-old male with ischemic heart disease who wasn't beta blocked. And the first time that we observed adrenaline-mediated spontaneous contractions was at 0.2 micromolar. Then as we progressed in concentration, you can see that spontaneous contractions had a greater amplitude. So if we just expand the scale just for this run of arrhythmic contractions here at 2 micromolar, then you can see what they look like. And they are irregularly arranged. They have different amplitudes and they have different time intervals. And they often are associated with an after contraction as well, so an unstable diastolic basal. Next slide quantitates the data, again for 22 consecutive hearts. And these have different etiologies. And you can see that adrenaline, looks like adrenaline causes spontaneous contractions. Statistically, they occur at concentrations greater than 60 micromolar. It looks like psilocybin, shown with the closed circles, the solid dots, potentiates the response to adrenaline and possibly also rolopram as well. And so if we summarise and conclude this work, both beta-1, we've shown that both beta-1 and also beta-2 adrenoceptors cause spontaneous contractions, at least in an experimental model of human ventricular arrhythmia. PDE3 and maybe PDE4 reduce their occurrence. But I think these studies already show the importance of blocking beta-2 adrenoceptors in addition to beta-1 adrenoceptors to reduce the likelihood of catecholamine-induced ventricular arrhythmias in patients with heart failure. And finally, I just want to move on to, and then there were 3 human heart beta-adrenoceptors. And I want to start off with this slide. In human ventricular, two very different responses to a beta-3 agonist, BRL 37344. A long time ago now, and I guess this work has sort of been bubbling away in the back of our laboratory for really quite a long time. So Chantal Garthier's laboratory showed that BRL 37344 caused a concentration-dependent reduction in contractile force in an endomyocardial biopsy. But in a human ventricular trabeculae, so these are really quite different preparations, well, we got nothing. But what about human atrium? And from the laboratory of Scabertus et al., they show that CGP 12177 caused an increase in contractile force in human atrial trabeculae. And this response was interpreted to be due to activation of a beta-3 adrenoceptor. Well, we also used CGP 12177, and it caused an increase in contractile force, and we interpreted this response to activation of a low affinity binding site of the beta-1 adrenoceptor. And studies, the first studies showing functional beta-3 adrenoceptors in human heart were all published in the Journal of Clinical Investigation. So I want to just go over the data in human ventricle. So this is the work from Chantal Garthier's laboratory, and she showed that isoprenaline, the beta-1, beta-2 adrenoceptor agonist, caused concentration-dependent increases in contractile force. But in the presence of a beta-1, beta-2 blocker, it caused concentration-dependent reductions in contractile force. And when the blockade of nadolol was overcome by isoprenolone, then you get this increase in contractile force. But very interestingly, noradrenaline, in the presence of nadolol, also decreased peak tension for concentrations ranging from 0.7 to 10 micromolar. So this was the work in with BRL 37344 that I showed you before, and it was also shown for a number of other agonists, including the beta-3 agonist SR 58611. So what happened when we did these studies in ventricular trabeculae, and note the different preparation, we used 4 beta-3 adrenoceptor agonists. We just used a single concentration, and guess what we got? We got nothing. And also, Sian Harding, at about this time, was published an abstract at the American Heart Association on work on human ventricular myocytes. So Sian was a real pioneer in the use of human ventricular myocytes and studying contractility. And has done some really, really very nice work in this area. But she published an abstract entitled Lack of Evidence for Beta-3 Adrenoceptor Modulation of Contractile Function in Human Ventricular Myocytes. So I want to move on to studies in human atrium. So over many years, we had developed the hypothesis that there are 2 affinity binding sites on the beta-1 adrenoceptor, a high affinity binding site and a low affinity binding site. So the beta-1 high affinity binding site is what I've been telling you about all this time. Noradrenaline and adrenaline activate it, and it is blocked by relatively low concentrations of beta blockers. But some beta blockers, typically CGP 12177 and clinically used pindolol, at much higher concentrations can activate the receptor, we believe through a low affinity binding site. And it can be blocked at much higher concentrations of beta blockers such as bupranolol and also carvedilol. And the reason, one of the early reasons that we called it a beta-1 adrenoceptor came from studies in mouse atrium from mice which had knockout mice, beta-1, beta-2 knockout mice, and beta-2 adrenoceptor knockout mice. And shown here are original recordings in the left atrium of a beta-2 adrenoceptor knockout mouse and a beta-1, beta-2 double knockout mouse. So firstly in the beta-2 knockout mice, so remember we've got intact beta-1 adrenoceptors here, and we incubate first with IBMX, a phosphodiesterase inhibitor that adds CGP 12177, causes an increase in contractile force, and isoprenolone causes a greater increase in contractile force. But look what happens when you don't have a beta-1 adrenoceptor. There's no response to CGP 12177, no response to isoprenolone, but there is a response to dibutyryl cyclic AMP, showing that the signaling pathway is intact. So the studies that we did with CGP 12177 closely mimicked seminal studies on recombinant human beta-1 adrenoceptors by Pack and Fishman. So low concentrations of the CGP 12177 cause an inhibition of cyclic AMP, but higher concentrations cause activation. So the molecular pharmacology of beta-1 adrenoceptors has been, of this binding site has been advanced sort of very nicely by studies by Gillian Baker and Steve Hill. But I want to go back to human atrium now. So this is the work of Scobertus, and they show that CGP 12177 caused an increase in L-type calcium channel activity. So these are 2 independent cells. So this is really quite elegant work, I think, to be able to patch 2 cells simultaneously. This L-type calcium current was blocked by a beta-3 antagonist, L748337. And this is what I showed you before, that in human atrium, that CGP 121.7 caused an increase in contractile force. And on the basis of these studies, they concluded that beta-3 adrenoceptors are positively coupled to the L-type calcium channels and contractility in human atrial tissues through a cyclic AMP-dependent pathway. But we were curious to know whether this effect could be blocked by the beta-3 adrenoceptor antagonist L748337. So we did this study. We set up 6 atrial trabeculae from one patient, right atrial appendage of a 51-year-old male patient undergoing coronary artery bypass grafting. And all tissues were incubated with IBMX, the phosphodiesterase inhibitor. Then the top 5 tissues were incubated with CGP 121.7, and you can see that it caused an increase in contractile force. Then these next 2 tissues were incubated with bupranolol, an antagonist of beta-1 low adrenoceptors, and the top 2 with the beta-3 antagonist L748337. And you can see here that bupranolol caused a reduction in contractile force, but the beta-3 adrenoceptor antagonist had no effect. So we did this study in a slightly different way. We carried out concentration effect curves to CGP 121.7 in the absence and presence of the beta-3 blocker, LY748337, and there was no shift at all by the beta-3 blocker. If a beta-3 adrenoceptor was involved, we would expect to get about a 1.5 or 1.6-fold 1.6 log rightward shift of the concentration effect curve based on a PKB value of 7.6. Okay, so what about electrophysiology? So this is work that was done by Torsten Christ at Dresden University of Technology. And so when you put CGP 121.7 on atrial myocytes, you get no increase in L-type calcium channel activity at 37 degrees Celsius. But if you inhibit IBMX, if you inhibit phosphodiesterases with IBMX, you get an increase in L-type calcium channel activity with CGP 121.7. So can you block this effect with the beta-3 antagonist? And the bottom left-hand panel shows that no, you can't. But what about with our beta-1 low adrenoceptor antagonist, bupranolol? And the bottom right panel shows, yes, we were. Okay, so what about at 24 degrees Celsius? So this is sort of really quite interesting. So we've got BRL 37344 in the top left there, and on the top panels, SR 58611 in the middle panel, so beta-3 agonist, and CGP 121.7 in the bottom panels, all caused an increase in L-type calcium channel activity. So could you block these with a beta-3 antagonist? Well, interestingly, you could block the effects of BRL 37344 and also SR 58611 with a beta-3 antagonist, but not CGP 121.7. So what about bupranolol, beta-1 low adrenoceptor antagonist? And it blocked the effects of CGP 121.7. And so we can conclude, at least from my laboratory, as yet, so are there functional beta-3 adrenoceptors in human heart? Well, as yet, we don't really have good evidence for functional beta-3 adrenoceptors in human right ventricular or atrial trabeculae, and I have to emphasise that these are trabeculae at 37 degrees Celsius. But we did see a small beta-3 adrenoceptor mediated L-type calcium responses to BRL 37344, SR 58611 at 24 degrees Celsius. And I haven't shown you this data, but they are uncoupled to inotropic responses, at least in our hands. So I would like to conclude this lecture by acknowledging those people that I've worked with. I guess one of the really good things about science and having worked in science or had the opportunity to work in science for so long is that you have the opportunity to work with some really wonderful and great people, and it really is just a joy. It is always just so much fun. the best part of it is actually spending time in the laboratory. And I thank you very much for your attention with this lecture. Thank you.